Carpal tunnel syndrome is a very common cause of numbness and tingling in the hand. It is a compression syndrome of the median nerve at the wrist and is sometimes referred to as median neuropathy or median neuritis. The carpals are the small bones of the wrist. They form a tunnel through which several structures pass, including flexor tendons and the median nerve. The median nerve branches out to provide sensation to the thumb, index finger, middle finger, and a portion of the ring finger. Motor branches innervate the thenar muscles on the thumb side of the palm and two of the lumbrical muscles. The transverse carpal ligament forms the roof of the carpal tunnel. It stretches from the scaphoid and trapezium bones on one side to the hamate and pisiform bones on the other. It is also known as the flexor retinaculum or anterior annular ligament. Increased pressure within the carpal tunnel compresses the median nerve. Sustained compression of the nerve can cause physiologic changes that interrupt communication to and from the branches of the median nerve. This is experienced as numbness, tingling, and pain in the portions of the hand innervated by the median nerve and weakness in the thenar region. Carpal tunnel syndrome has classically been blamed on workplace factors, such as prolonged typing and working at a computer, but studies do not support this. Instead, risk factors for carpal tunnel syndrome include other medical conditions that make the nerves more susceptible to injury, such as diabetes, or that increase swelling at the carpal tunnel, such as pregnancy or menopause. An inherently small carpal tunnel may also be to blame. The diagnosis of carpal tunnel syndrome is made clinically, based on a history and physical exam, and confirmed with nerve conduction studies and electromyography. Patients report numbness, tingling, and sometimes pain in the involved fingers. They may report weakness or dropping objects. Symptoms not limited to the hand should raise suspicion for other nerve compression syndromes, such as cervical radiculopathy. The hand typically has a normal appearance, except in more severe cases of carpal tunnel syndrome, in which the thenar muscles have atrophied. Phelan's test involves flexing the wrist to increase pressure on the median nerve. If this worsens the numbness and tingling in the involved part of the hand within 30 to 60 seconds, it raises suspicion for carpal tunnel syndrome. The carpal compression test involves simply applying direct pressure over the carpal tunnel. If symptoms worsen within 30 seconds, the test is considered positive. Mild early carpal tunnel syndrome can be treated conservatively. Cock-up wrist splints worn, especially at night, can prevent prolonged flexion of the wrist that increases pressure on the median nerve. Anti-inflammatory medications, such as ibuprofen and corticosteroid injections, can reduce inflammation and swelling within the carpal tunnel. If symptoms do not improve with conservative treatment, or if symptoms are severe, an EMG is obtained to confirm the diagnosis of carpal tunnel syndrome. This involves placing electrodes on the arm and hand and measuring the electrical activity of the nerves. Delayed or diminished signals along the median nerve distal to the wrist indicate carpal tunnel syndrome. Carpal tunnel release surgery is highly successful. Benefits generally greatly outweigh the risks, and recovery is relatively quick. A small incision is made at the wrist, exposing the transverse carpal ligament. The ligament is cut, immediately releasing pressure within the carpal tunnel. Theoretically, cutting the transverse carpal ligament can change the mechanics of the wrist and hand. However, patients do not tend to notice any instability or lasting effects and are almost always very pleased with the results. Recovery involves a short period of splinting and avoiding strenuous activity for a few weeks to allow the incision to close and heal. Patients with significant nerve damage due to long-standing severe carpal tunnel syndrome may not have complete resolution of their symptoms. Also of note, carpal tunnel syndrome can recur even after a surgical release. However, this is uncommon and typically occurs years later. The bottom line: carpal tunnel syndrome is caused by compression of the median nerve within the carpal tunnel at the wrist. Symptoms include numbness, tingling, pain, and weakness in the hand. Physical exam findings include increased numbness and tingling with Phelan's maneuver or carpal compression, and in more severe carpal tunnel syndrome, atrophy of the thenar muscles. The diagnosis is confirmed with an EMG. Mild carpal tunnel syndrome can be treated with splinting and anti-inflammatories. Carpal tunnel release surgery is effective, relatively safe, and has a short recovery period.